Welcome to Society Talk, presented by your American Cancer Society. I'm Mike, Senior Vice President of Corporate Alliances, and we are absolutely honored to have two of the leading public health experts on the topic of return to screening on our call today. First, I want to welcome our special guest, Dr. Ned Sharpless. Dr. Ned Sharpless is the director of the National Cancer Institute, better known as NCI. Prior to his appointment, Dr. Sharpless served as the director of the Lineberger Comprehensive Cancer Center at the University of North Carolina. Dr. Sharpless served as acting commissioner for food and drugs at the U.S. Food and Drug Administration for a time, but we are so happy to have him back at the helm of the world's premier cancer research institution. And joining Dr. Sharpless is the CEO of the American Cancer Society, Gary Reedy. Gary Reedy has dedicated his life to improving the health of people around the globe. He brought that vision to the American Cancer Society when he became Chief Executive Officer in 2015. Prior to taking the helm of the American Cancer Society, Gary has had a distinguished 37-year career as a healthcare business and advocacy leader. Gary has leveraged his firsthand experiences to transform the organization to build on its mission. Without further ado, Gary Reedy.
Howard, thank you so much for the introduction. And the first thing I want to do is I want to apologize to the audience. For some reason, my video would not work. My video and audio would not work. So I'm going to be on the telephone today, which I really hate. But this is such an important meeting today that we really wanted to continue and go forward. So I apologize for not being with you virtually in person, although I am here via audio. And Ned, I really want to thank you for being with us today. I know you're incredibly busy, but just thank you for taking the time out for this very important discussion. It's interesting that this year marks the 50th anniversary of the signing of the National Cancer Act. And I remember vividly when President Nixon signed it back in 1971. And if you think about the progress that we've made in cancer since that time over the past 50 years, and especially just in the last 5 or 10 years, it's pretty amazing, pretty phenomenal, actually. But unfortunately, all of that progress right now is at risk. And that's due to the significant impact on both cancer screening and cancer diagnosis that the pandemic has had. And Ned, I've heard you state on many occasions that you think one of the consequences of these delayed screenings could be potentially an additional 10,000 deaths from colorectal cancer and breast cancer alone that otherwise would not have happened. And I think everyone on the call will agree that that is a fairly stunning statistic. So, when you think about the disruption that the pandemic has had to cancer research and cancer care, Ned, I'd like for you to share with us, as director of the NCI, on exactly what does that mean for progress against this disease years from now.
Yeah. Thank you very much for the opportunity to come and talk today on this important topic. And I want to thank the ACS particularly for their leadership in this really difficult time and helping to sound the alarm on the issues you just mentioned. It's important to sort of talk about where we've been. Since the early 1990s, cancer mortality in the United States has been steadily declining for lots of reasons. Tobacco control is a big part of that. Better prevention and screening is a big part of that. New therapy is a big part of that. In the last few years, that rate of decline has actually accelerated. So it had been pretty good news. There's a very exciting time in cancer research. Lots of new ways to prevent, diagnose, and treat cancer. Something on the order of hundreds of new FDA approvals over the last few years for both new drugs and supplementary indications. So a really exciting time of cancer progress, an acceleration in the decline in cancer mortality, and then the pandemic has happened. And the pandemic has been extraordinarily disruptive to lots of things that are important, including cancer research and clinical trials, but also really cancer care. So we've seen widespread disruptions to cancer screening, people not coming in for mammography or pap smears or colonoscopy or low-dose CT screening for lung cancer. We've seen delays in diagnosis or failure to diagnose because symptomatic patients with new symptoms of cancer are not going to their doctor to be evaluated because of fears of coronavirus limiting clinical care and inpatient visits, for example. And then we've all seen, this delayed decreased screening and decreased diagnosis also be combined with deferred or delayed care. So we have evidence, for example, that mastectomies and colorectal surgery for cancer, those things are down because patients are unwilling to come to doctors, or because clinics and hospitals even have been closed or deferring care because of the pandemic for some period. So all of those things together have really provided immense disruption to clinical care and to new diagnosis of patients. And as you mentioned, the NCI did some modeling as to what the impact of that could be. We only did it for colon cancer and breast cancer, as you mentioned. Those are two kinds of cancer we have the best, most sophisticated models where we think we can really get the best handle on this problem. And in just those two cancers alone, we anticipate the possibility of a 1% excess mortality over the next decade from those cancers, which would, as you mentioned, translate into 10,000 excess deaths. So that just for those two cancers alone, and we don't think there's anything about that analysis that would be just specific to those two cancers. We believe there could be similar disruptions and increased mortality from other kinds of cancer like lung cancer and pancreatic cancer that we didn't model. So, what we're worried about is an excess mortality bump that would play out over the next few years related to these disruptions I mentioned. And so I think that really the burden on us now is to collectively take action to make that not happen, to make the impact of the pandemic as minimal or as modest on patients as possible. And that's very challenging, but I think there are a lot of things we can do to decrease the impact of the pandemic on our patients and get back to that stable trajectory of progress against cancer that we've been seeing prior to the pandemic.
Yeah, well, no, and thank you, Ned, and thank you for your leadership, and certainly here at the American Cancer Society, we are helping lead a significant effort of return to screening to make sure that people that did delay their screenings last year get back in as soon as they feel safe to be screened, because as you said, we know there's a lot of people, unfortunately, out there walking around right now with active cancers and they're not aware of it. And we do need to do everything we can collectively to make sure that we don't lose that momentum that we've seen over the since the early 90s. Something else that the pandemic has really shown a spotlight on is disparities. And certainly, here at the American Cancer Society, we've been focused on disparities, health disparities, just like you have at the NCI for many years now. But unfortunately, the disparity burden has been has really increased, especially due to COVID, and in communities that have been historically marginalized. So we have the issue of people postponing or skipping their screenings, but now we also have this other issue of disparities that has intensified as a result of the pandemic. So my question is, how can we here in the U.S. minimize the pandemic's impact on disparities and ensure that those same disparities don't continue to exist in our return to screening efforts?
Yeah, I think this is a really important topic, and I'm so glad that the ACS is interested in this topic and is getting the word out to all their supporters and stakeholders. It is not a surprise to anyone who's interested in cancer care and cancer research that there are tremendous inequities in healthcare delivery in the United States. Cancer health disparities has been a topic of focus for the NCI for decades, and particularly in recent years, where we now spend on the order of $500 million a year on cancer health disparities research, and the issues of access to care and high quality care and allowing and access to screening and other interventions are very well known to cancer researchers and the challenges those things propose. Then on top of that, now the pandemic has occurred and really laid bare and made quite explicit the strong disparities that exist in the American society with regard to healthcare access and outcomes. And so that, I think, adds an additional wrinkle to this topic of, we have the pandemic disruption superimposed on, longstanding healthcare inequity, and how are we going to particularly minimize the impact of the pandemic with regard to cancer on these underserved populations, these underrepresented minority populations. It is still an open research question in my mind as to how bad this is going to be. So, for example, we know with regard to screening, like say mammography, that was initially cut across the board. Mammography basically was decreased by more than 90% in all populations. The NCI follows affluent and poor, good access, bad access, very widespread disruption. But now, as we're seeing return to screening, we believe that some populations are going to come back more quickly than others, and we expect to see a rebound in screening in the populations that have the best access to care, for example. So I've already seen data, for example, from the CDC that suggests, like mammography, there may be a particular challenge in the tribal nations with the American Indian population, for example. That might be a population that really is at risk for delayed return to screening, for example. So this is a research question that the NCI really needs to ask. Are there, of the pandemic's many disruptions, which are the most important for underserved populations? And so certainly we have already provided funding to various institutions to study these questions. We are very particular, are there new approaches or new technologies that can help mitigate this impact? So, for example, telehealth is very much in the news these days. We have this widespread broad adoption of telehealth with the pandemic. And is that a problem, or is that a solution? I mean, will telehealth allow us to find these communities with decreased access and reach them in a way that was perhaps not possible before? Or will certain communities that don't have good broadband access and don't have good internet access, for example, will those communities disproportionately suffer with a broader adoption of telehealth? So, a new exciting technology and a new exciting approach like that, its impact on the disparities question is still, I think, unknown. So clearly, these are things the NCI plans to study, as well as work with groups like the ACS and ASCO and the American College of Surgeons and ASTRO and the many and AACI, for example, that are very interested in helping to address this problem of inequity of cancer care as the pandemic sort of goes away and we resume more normal care.
Yeah, we certainly feel, as you do, Ned, that that no one should be disadvantaged in their fight against cancer, and as you referenced, there was a huge challenge in with disparities in cancer in those marginalized communities prior to the pandemic. And then, I think the real opportunity here, as you said, is to really understand post-pandemic, what have we learned and what can we apply going forward to really address this issue in earnest to the extent that we can. And, I agree with you. I think telemedicine, telehealth could be, I love the way you phrase it, is it good or is it bad? I'm one of these people that the glass is always half full. So I hope that we take advantage of our learning and the way we all had to pivot and had to adjust, during the pandemic, to apply those learnings to address some of these age-old problems that we've had, both around, health equity and disparities, and particularly, for all diseases, but certainly also in cancer, because we know for a fact that we will never be able to get ahead of this disease or to manage it as chronic disease until we address these health equity and disparity issues. And we are very committed, just as the NCI is, to play our role there in doing that. You mentioned when we were talking about screening and the importance of getting the message out there to all communities, to get back in for screening. And, the question I'd like to pose to you today that I think everyone on the call would be very interested in, because I think all of us have a role to play, is, what role can companies play in helping address this issue of making sure people are getting back in to get to screening? That's part one. You know, and I would say companies, and I'd say companies and individuals, because I think all of us can play a role there. And then anything you can share that you've seen or are seeing from an innovative ways to get people reengaged with cancer screenings.
Right. There's a lot of things there that I think are exciting opportunities. I mean, first of all, many people work for companies. The workforce is a large number of individuals, and I think companies that adopt a very forward-thinking posture to the general health of their employees will encourage screening and will encourage return to screening and will try and talk to their employees about wellness. And cancer surveillance and cancer screening is a big part of that. So I hope that employers large and small will really encourage their employees to the extent allowable that they should consider a resumption of screening. I think helping to communicate about this topic just at all levels is really important because I think there has been some coverage of it in the media, but there's just a lot going on right now, and this message and the importance of this message is sort of competing with lots of other stories right now, and so I think while word has gotten out, it hasn't gotten out completely, and it hasn't gotten out to all populations. So any help in communication is very appreciated. Beyond that, though, I think cancer screening, as you know, was a really interesting area of cancer science prior to the pandemic. I mean, there was a lot of exciting things going on in this area in terms of new innovation and new opportunities. And then the pandemic, in a way, has made this topic and some of these trends even more exciting and of greater interest at the moment. So, for example, the movement to screening in a clinic, to home-based screening, was something the NCI has been working on for a long time. Think about cervical cancer screening. That's now done mostly by pap smears in a doctor's office, but there might be self-sampling technologies that would allow patients to screen for cervical neoplasia without going to a doctor. This is really appealing for communities that don't have access to a physician that does pap smears, or say low and middle income countries where cervical cancer is a huge problem, right? So the movement from clinic-based screening to home self-sampling screening, which is very much an issue in cervical cancer and colon cancer, for example, those trends I think have been accelerated by the pandemic, and if those topics are of even greater interest than before, and there are a number of promising technologies that are under development along those lines. I think also, there was a lot of interest in these multi-cancer detector technologies and blood-based tests that sample cell-free DNA and exosomes and other approaches. And there are many of these technologies. And, now that screening is in the news very much, I think there's been some acceleration and interest in those topics. And they really represent, I think, a remarkable opportunity to diagnose cancer earlier for lots of patients for cancers where screening has not been as successful. One thing we're talking a lot about at the NCI these days with regard to cancer screening is low-dose CT screening for lung cancer. That is the newest of the, I think, accepted screening modalities. Several large randomized trials have shown the benefit of low-dose CT screening for appropriate populations. The United States Preventative Services Task Force has recently revised their recommendations to allow to expand the eligibility of that. So now there are millions of Americans who are eligible for low-dose CT screening based on age and smoking history. And that is a approach that has been vastly underutilized in the United States. And now with this increase in eligibility, it's even more underutilized, if you will, on a percentage basis. And we think this is a real opportunity for to decrease lung cancer mortality, for example, by broader adoption of that. And so that's very much in the focus. Just like all other modalities of cancer screening, we know low-dose CT screening was also very disrupted by the pandemic, cut to negligible levels, if you will. And so now as we're talking about screening, I feel like this is an opportunity about this new kind of screening that is somewhat underused, is particularly underused. I would argue all cancer screening is underused, but low-dose CT screening is the most underused, if you will. And sounding that message and getting patients appropriately screened for lung cancer as well. So those are a few of the opportunities where I think industry could be very, very good partner for making progress in cancer outcomes. But there are many more.
Yeah, no, thank you for sharing that insight, and we absolutely agree with you. I think that the changing the guidelines for the low dose CT screening for lung cancer is truly significant. And like you said, just expands the audience. To where hopefully we'll be able to detect a lot more of these lung cancers early on, when they can be treated and be treated successfully, and certainly the blood-based screening technology that's coming out is truly exciting, and there's some tried and true ones out there, and certainly through the National Colorectal Cancer Roundtable, we've been working with the members, really, as you mentioned earlier, to try to get people to at least, at a minimum, use the at-home stool-based testing, for colon cancer. So I think that there are a lot of tried and true technologies out there. There's a lot of emerging technologies that are exciting. Certainly, mentioning telemedicine, as you well know, the number one reason people do get screened is a direct recommendation from the provider. So hopefully, telemedicine can be used to connect more providers with, people in all communities, but especially underserved communities, so that they can get that recommendation and we can get them screened. Well, listen, we want to allow some time for questions. So at this time, I'm going to turn it back to Howard. And Howard, if we have any questions coming in, I'd like for you to go ahead and ask them, please.
Sure, Gary. So Dr. Sharpless, this question came in. I know our focus today has been on COVID-19 and returning to screening, but can we have an update on the cancer moonshot? What do you see as the moonshot's most meaningful contributions to the field to date, and where do you see the program going?
Sure. Thank you for the question. The Cancer Moonshot is just starting year 5. For those of you who followed this, Congress appropriated $1.8 billion of new money to the NCI over a 7-year period. So we're in year 5 of 7 planned years of funding, so a little more than the halfway mark of the moonshot. The goal of the moonshot, if you remember, a blue ribbon panel was convened. It identified, high priorities of focus, focus areas, and they were largely quite translational. So the idea was to take things that were just about ready for human use or just entering human use and rapidly accelerate their adoption and uptake. And so that led the NCI to create a number of funding opportunities, which stood up new networks and new programs and new initiatives. And it's really an extraordinary number of new exciting work. So on our website, we have cancer.gov, we have extensive information about those programs, but it's sort of overwhelming. There are like 240 new initiatives that have been stood up by the Moonshot across those 10 or 11 blue ribbon panel identified areas. And these are really quite translational, substantive efforts. So, for example, we have a new network to do immunotherapy in pediatric cancer. We have a new initiative at patient engagement. So trying to use, putting the power in the patients to come to us through the internet to enroll in clinical trials. We have many new efforts to sort of identify new drug targets or drug discovery efforts for high quality targets for cancer drug discovery. We have a very substantial effort to the development of needed infrastructure for data sharing. So the Cancer Search Data Commons, which has many the data sets that are of use by the extramural scientist community, are really supported by the Moonshot. So it's really a tremendous number of important and I would argue quite successful efforts. And I think it's taught us a number of really important things about these kinds of efforts in general. One of the things that I think has really been interesting about the Moonshot is it has kind of a radical data sharing mandate. So all the work that's coming out of the Moonshot, those data are made available and shared and put on the Cancer Research Data Commons in a real-time way that is somewhat new for the NCI. I think it's becoming kind of the pattern for data sharing across federal government, if you will, including the rest of the NIH, and already is a direct benefit. But some of these other, more clinical trials initiatives are going to take a little longer to play out, but I think it's off to a terrific start, a little more than the midway point on.
Thank you, Dr. Sharpless. Here's another question. Given the uniqueness of this past year, Can you reflect a little bit on what were some of the most important lessons NCI learned in 2020 and obviously the first part of 2021?
Yeah, well, I think we've learned a lot. We talked a little bit already about things like telehealth and the research opportunities provided by the pandemic, so I won't mention those again. But one of the things I think that we've learned that I think is a good thing to have learned, a quite important thing to have learned, is new ways of doing clinical trials. So we had to change how we do clinical trials quite a bit during the pandemic, even despite what I think were fairly aggressive changes to clinical trials. The way we do them, accrual did suffer significantly during the sort of the height of the pandemic months. But we did things like we allowed the consent for the trial to occur by phone. That seems obvious. I would argue we probably should have done that years ago, but the pandemic really, working with the FDA, forced us to adopt, teleconsent, for example, which I think is a big deal. We found out that we could mail investigational drugs that were oral directly to the patient. So, these IND drugs could go by mail to the patient rather than requiring them to go to an investigational pharmacy. Again, that saves the patients a trip. That is probably something that is we should have been doing a while ago, but is a positive development. And there are many, many other changes about how care is delivered in a clinical trial and allowing for care to be given more locally or to skip visits or to just make trials simpler. And these have been very popular. So patients have really liked these changes, and as have the clinical trial doctors that perform these trials. So I think the NCI has learned a lot about clinical trials, and we will not be going back to the bad old days. We are going to keep many of these changes on beyond once the pandemic is over, because we think they're good for clinical trials. I'll say another thing that we've learned that has been very important to know, and I knew already, but really lived it in the pandemic, is that when the NCI needs to, it can move very, very quickly. So we were appropriated new money by Congress in April of last year, and to the tune of $306 million to do a bunch of new COVID science, while all simultaneously doing our cancer work. And I think the National Cancer Institute rose to that challenge and really did some extraordinary stuff, including testing a bunch of devices for the FDA at Frederick National Lab, standing up this serology seroprevalence data set for the CDC, working with many other parts of the federal government, including BARDA and NIST and the Department of Defense on various initiatives that were important to the coronavirus response, and created a clinical trial of the outcomes of COVID infection in cancer patients that is now accrued more than 1,000 patients and open at many greater than 1,000 sites in the United States. And that trial was really stood up in 6 weeks. So the notion that a clinical trial takes 18 months to develop at the NCI is just untrue. So I think we found out that when we need to address a question very quickly, the capabilities to do that exist within the federal government, particularly exist within the NCI. And so that is also something that I think we will remember that lesson from the pandemic and will be important going forward.
Dr. Sharpless, I think we have time for one more question. We're simulcasting via YouTube, and this comes through that channel. The question is, are there any new developments in proton-based therapies?
Sure, this is an important topic. So for those of you who are not aficionados, well, not radiation oncologists, the traditional modalities used basically photons, use X-rays. And there have been a movement to use the higher energy particles to treat cancer, culminating, with proton therapy, and now even heavier particles are being discussed, such as like carbon nuclei, for example. So the benefits of these particles that make sense from a basic science point of view, the ability to deliver the energy to the tumor in a more spatially controlled way and in a way that might kill the cancer better, makes sense at a basic science level, although the infrastructure to create the various kinds of devices needed to treat patients is quite expensive and challenging. So proton therapy has been developed extensively across the United States and is now widely available, but it was developed in such a way that in many cases we don't know if proton therapy is actually superior to the old way of doing radiation oncology, the older way of doing radiation oncology using X-rays. And so the NCI has been working on a number of clinical trials to compare them head-to-head, so randomized trials to understand proton therapy better or equivalent to other modalities of radiotherapy. And those trials have been slow to accrue for a variety of reasons, but are now well underway and are starting to read out. the question really is twofold. Is proton therapy more effective at treating the cancer? Is it better efficacy as an anti-cancer approach? And also, is proton therapy any safer? Is it less toxic than traditional radiotherapy? And both of those questions are being investigated in a multitude of diseases at sites in the United States with NCI support, as well as sites in Europe with other funders. What I can say is that the answers are complicated. This is going to play out over a while. I do suspect in some indications proton therapy will ultimately be shown to be superior, at least in terms of safety, if not also efficacy. But not in every instance. And so the question of cost and convenience and availability all loom large in this topic. And everything I just said is the complicated issue of protons versus more traditional radiotherapy. But these same questions are now being asked for higher, for even larger particles such as carbon nuclei. And it's a very vigorous topic in the radiation oncology community now as to what extent the United States should invest in these technologies and what role the NCI should take in supporting such trials. And so this is a question we're working on, with great interest at the present moment.
Well, thank you very much. Unfortunately, we run out of time. So first, I want to say on behalf of the American Cancer Society, we want to thank our special guest, Dr. Ned Sharpless, and thank Gary for his leadership in the fight for a world without cancer. That concludes today's Society Talk. Have a great day.
Thank you for having me.